I got my labs done. You guys will want to know what they are. Let's get into it, the good, the bad, and a little bit of the ugly. We will not be doing a super deep dive into lipids. That will be another video for another day. If you are new here, I am Dr. Lily Johnston. I'm a board-certified vascular surgeon, but I specialize in cardiometabolic prevention, so hopefully you will never need me as a surgeon. So let's start with a complete blood count, or CBC. Almost all of you will have had this done in your doctor's office with your annual visit. Let me show you what I pay attention to. The first thing we see here is WBC, or white blood cell count. That is typically going to be normal for most people who are not having any signs of active infection. White blood cells, of course, are the infection cells and fighting cells and are related to immune system. So 6.4 thousand white blood cell count, very normal, no concerns there. Hemoglobin and hematocrit are the next two that I'm going to pay attention to. I kind of skate past that RBC, it's the total number of red blood cells, but the hemoglobin, which is the iron carrying molecule, and the hematocrit, which is a concentration of red blood cells in your total blood volume, are the things that clinically we pay the most attention to. This is relevant for a diagnosis of anemia, for example, low red blood cell count, or maybe something like erythrocytosis or too many red blood cells. That can sometimes happen to men, especially who are on testosterone replacement therapy. So for women in particular who are still menstruating, you would look to see, make sure they're not anemic. So my hemoglobin is 13.2, hematocrit is 42.2, squarely in the normal range, no concerns. The next one is a nice little clue. It's the MCV, or the mean corpuscular volume. This is the size of your red blood cells, and it ranges 88 to 92 is kind of the average size, I would say. And in the low 80s, you get something called microcytic, usually anemia. If your red blood cells are very small, you're often going to be deficient in some red blood cells. And so that is a microcytic anemia. The cells are too small. And if you're above in the 90s, say mid to high 90s, then you're going to have a macrocytic anemia. And the size of the red blood cells tells you a lot about what's happening in the bone marrow and what else might be going on. So at 88, this is normal. It does not flag as too big or too small. In my patients who have red blood cells that are a little generously sized, like 93, 94, I think about whether their homocysteine may be elevated, whether they may have an MTHFR mutation, because B12 deficiency is one of the things that can be associated with a macrocytic anemia. And if red blood cells are big, even if you're not anemic, it's just a little flag for me to make sure that I ordered and interpret a homocysteine level for you. At 88, mine are, again, average size, but it's a little on the smaller side. And I'm going to pay attention to my iron levels, which we will see coming up here shortly. MCH, MCHC, RDW, these are some of the things that if you are a blood specialist, like a hematologist, you find very, very interesting. Most of the rest of us will gloss right past that. The next one I'm going to pay attention to is the platelet count. So platelets are the non-nucleated sticky things that help start clots in the bloodstream. And again, if you cut yourself and are bleeding, clotting is great. If you have a plaque rupture event, clotting is your body's natural response to that, but it is a problem for your downstream organs that are not going to get the blood supply when that clot blocks off your coronary arteries, your cerebral arteries, what have you. In general, a normal platelet count is anywhere from 150,000 up to about 450,000. And that range is fine. Usually on the higher end of that range, I start being a little bit worried about signs of inflammation. If you're under 150,000, I'm starting to wonder about liver dysfunction or any issues like that. If I had to pick a perfect number, right, somewhere in the low 200,000s, like 234,000, for example, would be a great number to have. Anything higher than that, 250, 300, 350, it's not wrong. It's not abnormal. But I worry that maybe there's a little more inflammation going on in the body. That's not substantiated by a large body of literature. It's just kind of the gestalt that I take into the rest of my lab interpretation. And, there's nothing wrong with a platelet count of 350,000. Don't take away from this that there's anything pathologic about it or there's anything wrong with it. There's not. It's just part of the bigger picture. Okay. MPV is the platelet volume. I don't pay any attention to that. Nucleated red blood cells, the NRBC, I don't pay much attention to that either. If these things were to be abnormal, I would generally phone a friend and try to figure out what's going on. Sometimes things are just abnormal because statistically, if we take enough tests, we'll have something that pops outside of the normal range. And sometimes it's really meaningful. So this is why it's always good to have some friends who are expert in all different areas. So when you have something that shows up as abnormal, you can figure out whether it's kind of just what we call a laboma, right? An abnormal lab situation that's not really that clinically meaningful or relevant, or if it merits a deeper dive and further investigation. The next thing is the differential. We're not going to spend a lot of time on this, but it shows up in all of your lab tests. So I thought we would go through it just quickly so that you will know what it is. White blood cells have many different types and subtypes. And when we think about the function of our bone marrow, the health of our bone marrow, and how we are manufacturing different types of cells, we look at the distribution of all the different types of white blood cells that we have. And that can tell us things about, for example, an acute infection versus maybe a leukemia or other abnormal things in the bone marrow. Most of the time, this is going to flag as normal for people. There are some weird oddball things like eosinophilia or high prevalence of certain types of cells called eosinophils. And if that happens, we can cover it. But by and large, most of the time, this flags as reasonably normal as long as you're healthy when you're getting your labs checked. And we don't spend too much time on this. My differential, again, you'll see nothing here is flagged in red. This is all normal, and I glossed over it pretty quickly. Okay, chemistry profile. So I was dismayed and distressed to see my fasting glucose was 96. For me, that's a little bit on the higher side. And I was really stumped by this until I remembered that I had my labs drawn post call. So on call for me is sometimes a stressful event. Sometimes it means I get woken up or even have to be in the hospital all night at a time. And so this particular night, I think I had gotten woken up by phone calls multiple times. I don't think I was operating the night before, but that alone will elevate your glucose, right? It disrupts your sleep. It increases cortisol, our stress hormone, and cortisol, especially in the morning, does create this dawn effect where it tends to be where we see higher levels of glucose. So I'll show you the rest of my metabolic stuff later, and we'll see that this was not a consistent finding, but I was a little disappointed to see the 96, and I think I have a good explanation for it. But all that to say, if your fasting glucose on a chemistry panel, especially if you were checking your labs in the morning, was done after a poor night of sleep or after a stressful event, travel, jet lag, something, then just keep that in mind and you can always recheck that. Okay, the next thing we'll talk about are salts in the blood, the various electrolytes. So sodium, potassium, chloride, carbon dioxide or CO2. And what I tell patients about this is your body will go to extraordinary lengths to keep these numbers normal, and they don't necessarily reflect what's happening in the cells. So some of these ions or electrolytes like potassium are found much more on the inside of cells than circulating freely in the plasma, and you just don't know what's happening. In particular, this is relevant for magnesium. So people wonder if they are deficient in magnesium and should they take magnesium supplements. A measured serum magnesium level won't really answer that question. Even a red blood cell magnesium level may not be the best way to answer that question. It's better. And it's, again, measuring what the concentration is in red blood cells rather than freely floating in the plasma. But your kidneys and the homeostatic organs in your body are going to, again, do everything in their power to maintain these levels in the normal range if they can, because they are so central to how our body functions. All of the signaling in our body relies on gradients and different concentrations of these electrolytes and salts. So all that to say, just because these are normal in your labs doesn't mean you don't need electrolytes, doesn't mean you shouldn't supplement sometimes, depending on what's going on. That's a more nuanced conversation. We just don't see it very well in lab testing. All right. So I'm not going to spend much time on anion gap. That is something that is useful like in the emergency department or in the hospital if patients have these electrolytes really out of whack or they're building up acid in the blood. That's when the anion gap becomes useful. In the outpatient setting, most of the time that's going to be normal. Again, if it's flagging normal, I'm not paying attention to it. It doesn't tell me a lot of useful information. The next thing we're going to look at is kidney function, urea nitrogen, and creatinine. So this reflects your body's ability to clear some of the toxins from your body. It does not necessarily reflect your kidney's ability to keep some of the good things in your body, and it is not the most sensitive test. Now, I did not check a cystatin C, which would be the other thing if I were really worried about creatinine or renal function, kidney function in a patient that I might check. The other thing I did not check for myself would be a microalbumin to creatinine ratio. That is a really good test, and I ordered in most of my patients. I'll tell you why I didn't order it for myself in a second. It reflects your kidney's ability to keep protein. The kidneys are a remarkable, fascinating organ. Okay, I'm sorry, it's super nerdy, but the kidney has to excrete all these toxins, but the library of things that the kidney might have to learn how to excrete is enormous, right? It didn't know about this supplement or that toxin or any of these things. So the way the kidney was designed is it actually gets rid of everything in the bloodstream that it can, and then it reabsorbs the good stuff. And what's left is the toxins that we're not supposed to need, because the number of things we want to keep is a very finite, short list. So the kidney's job is to sort of dump all this stuff into the tubules and then reabsorb the good things. And protein is one of the good things we are supposed to bring back into the kidney or into our circulation. And we shouldn't be spilling protein into our urine. If we are, then I think of it kind of like a leaky chain link fence on a playground where the balls that kids are playing with are actually getting through the fence because it's broken and not keeping things where they're supposed to be. And that is typically a sign of insulin resistance or even diabetes, or really poorly controlled high blood pressure over years. So frequently I will check microalbumin to creatinine ratio in my patients. I didn't check it for myself this time. It's a urine-based test and I was in a hurry and didn't want to do it in the lab. And I check my blood pressure pretty regularly, and we'll see my metabolic results here. If those had flagged as abnormal, that is absolutely something I would have added. And I have checked mine before. It's been normal, but it truly, if I were being really complete, should have been in there as well. The cystatin C you could do as an add-on after the fact if the creatinine were elevated and you were concerned. Some people do it routinely with regular labs. Um, it's a bit more expensive and it's a little bit more niche. And so sometimes I just don't order that as the baseline. But certainly if I have concerns about somebody's kidney function, adding cystatin C to a BUN and creatinine can be a very helpful way to more precisely estimate the kidney's ability to get rid of toxins. Okay, osmolality, not super worried. CKD, EPA, EGFR. This is the estimated glomerular filtration rate. Excuse me. This is again a calculation based on the creatinine that estimates how much the kidney is filtering at any given time. And the higher this number, typically the better. So an EGFR of 100, anything over 100 is great. So no concerns about my kidney function. And that's in the setting of a decent amount of creatine and muscle mass. So good for me. Okay. The rest of the chemistry panel includes calcium. So I always pay a little bit of attention to calcium in my patients, including myself, who are on vitamin D supplementation. People worry a lot about excess vitamin D or taking too much. If you're going to get too much vitamin D, where you're going to see that problem is with too much calcium in the bloodstream. The side effects from hypervitaminosis D or excess vitamin D, all to do with too much calcium, because the vitamin D allows us to absorb more from the intestinal tract. So anybody who's on vitamin D supplementation and is going to have probably above normal or above average levels, I will just take a quick gander at calcium and make sure that that is well within the normal range and we have no concerns. At that point, I don't really care if your number is 80 or 100. Do you need that level? Nobody knows, but it's not going to be harmful as long as your calcium is normal. Alkaline phosphatase, albumin, total protein, these are kind of related to the liver and the biliary system. Again, most of the time people have relatively normal values of these, and I don't pay over much attention. Uric acid is something I tested specifically for me and for many of my patients. This is a metabolic marker that gets elevated when we have too much of certain things, and it's implicated in gout. It forms crystals in the joints and also in the bloodstream when the concentration is too high. What's too high? Over 6 in a woman, over 5 in a woman, over 6 in a man, I would say is elevated and would raise my eyebrows. Anything in the 7 range, we start to think about treatment or making significant changes to reduce uric acid. The big culprits tend to be fructose and purines are a specific kind of protein that can raise uric acid levels in patients. So if your uric acid is high, it can be related to high blood pressure. It can be related to gout. It causes all kinds of bad things, even in the brain, that we don't like. So I like to keep an eye on the uric acid levels. And if I have patients who have elevated levels, then we think about how we might choose to mitigate that, starting, of course, with nutrition and making sure that that is not the cause of high uric acid levels. AST and ALT. These are what people typically call liver function tests, but I call them liver dysfunction tests because they will go up when your liver is pissed off. And we can see this in fatty liver disease or metabolic associated steatohepatitis. MASLD is the new name for this, non-alcoholic fatty liver disease. And so AST and ALT will be elevated. You can also see it as the side effect of drugs or supplements. They may raise your liver function tests. And an optimal level is probably under 20. And if we're in that range, we think we're in quite good shape. I have lots of people who are sort of in the 20 to 40 range. If we're there, I ask, are we on any new medications, any new supplements, anything like that? And what's the diet been like? Because a little bit of excess energy will sometimes trigger an increase in AST and ALT. Alcohol is the other one that can do this. And if you're seeing elevations in these liver dysfunction tests in patients, always just get a drinking history, but it's a late finding for that. So the other thing you may notice would be going back to our blood counts, low platelets. That's another measure that the liver is unhappy and sick in some way. So my AST and ALT are in a pretty good range. Bilirubin is it's the thing that makes bile green, and that's secreted by the liver. And total bilirubin at 0.5 is perfect. Okay, so we are going to move on into other chemistry. So I promised you my vitamin D levels. As I said, I do supplement. My level is 62 before supplementation. That was a few years ago. I don't have an old value to show you, but I'm pretty sure I was in the 30s to 40s. I was not adequately replete in vitamin D, as you might guess by my very tan appearance. Homocysteine. Homocysteine is a marker of B vitamin metabolism. It is in the methylation pathway. So the B vitamins that we eat in our diet have to be activated or turned into the active methylated forms for them to do all the things in our body that they do, which is actually a lot. And homocysteine is a marker in the middle of that conversion process. If homocysteine is too high, we are not efficiently doing all that conversion because this byproduct is building up. It's like soot in a messy, like poorly burning fire, right? It's not nice, clean. It has this intermediate stuff that's junky and is gumming up the works. Elevated homocysteine is associated, probably causally, with heart attacks and particularly stroke. The Cochrane review with heart attack was not very compelling, and we can talk about that was for treatment of homocysteine. Longer video for another day. Anyway, it is associated with heart attack, stroke, plaque formation, and atherosclerotic disease. If homocysteine is elevated, I like to help patients manage this by adding methylated B vitamins. That will usually bring that down. Mine is 6.5. The optimal level is probably less than 8. I will accept less than 10 as good. Most labs won't flag it until it's over 15. And I have many patients in my vascular practice who show up without a lot of other reasons to have vascular disease. When I check a homocysteine, it's like 16, 20. It's super high. So I've caught this a number of times for patients, and it's kind of a nice thing to be checking. If you're usually in the normal range, you probably don't have to check it all the time. Mostly this reflects people who have a genetic problem with that conversion from inactive to active forms of the B vitamins. So MTHFR mutation is the most common one that people know about, for kind of cute reasons like the way that it's spelled. But there are many genes in the methylation pathway that can be impacted and can result in elevated homocysteine or low levels of methylated B vitamins. So I like to check this. Some people also check methylmalonic acid or MMA. I don't do that routinely, but it's another thing that you will see in more extensive lab panels. Ferritin. Ferritin is the iron storage molecule. So I don't have the rest of a complete iron panel here. I wasn't overly concerned about it, so I just checked my ferritin. 37 is fine. It's not really high, and there are a couple of disorders of iron storage where like hemochromatosis is the one I'm thinking of, where ferritin levels will be sky high even without inflammation. And ferritin is also an acute phase reactant. So in patients who have an active infection or are inflamed for any particular reason, ferritin levels will go up. So if you check them in somebody who's in the hospital with cellulitis or a skin infection, for example, you'll see that ferritin is abnormally elevated in those patients. Again, in sort of the normal, I feel reasonably well, I'm just screening my labs to see if there's anything going on setting. Typically, this is, again, related to an iron deficiency situation, and menstruating women are the most susceptible to this. You can be iron deficient without being anemic, and you may actually be symptomatic from that. So something I checked for myself. 37 is not bad. I would say in the teens is where we start thinking about severe iron deficiency. I probably just my current multivitamin doesn't have iron in it. I'm considering adding it just to see if I can top up my ferritin a little bit. I don't know what that's really going to do for me. We can talk about that another time. If you have questions, put them in the comments below about that. But my gestalt is I might want that just a little higher. I don't know. It's maybe just noise. Moving on. Okay, I promised you that there are some of my labs that are not great and not perfect. Here is the big one. It is my fatty acid analysis, or my omega balance. So this is the analysis of the omega-3 fatty acids and the omega-6 fatty acids in my bloodstream, and trying to see, are the ratios balanced? Is this pro-inflammatory? And I'm not doing great on my fatty fish. And even my supplementation of omega-3 fatty acids has been a little spotty. And so you can see my EPA plus DPA, which is an intermediate, and DHA. Those are the omega-3 fatty acids. That is a percentage of 3%, and that's pretty low. I would love to see that in the over 5 range, really like over 6, 7, 8% would be great. I'm not getting there by myself. So I need to up my supplementation and really prioritize more fatty fish in my nutritional approach. So even though I like fish, I don't fix it for myself super often. That's something I'm going to have to work on. You can also see that the arachidonic acid to EPA ratio is elevated. Arachidonic acid is a metabolite in the omega-6 pathway that's related to inflammation. And basically, this is looking to see, is there an inflammatory milieu or mixture of the fatty acids in my bloodstream? And the answer is yes. And it's really more about not enough EPA rather than too much arachidonic acid, because my arachidonic acid levels, as you'll see below, are 13. They're not sky high. Linoleic acid, omega totals, you can see all those there as well. The seed oil thing is a very tempestuous situation right now, and I have lots of feelings and thoughts about this, some of which are substantiated by the evidence and some of which are not. What I have taken away is that, your intake of omega-6 fatty acids is not necessarily super well reflected immediately in these panels. Those fatty acids can get integrated in our cell membranes and into our subcutaneous fat, and they can stay with us for a very long time. So I have made some efforts to reduce the omega-6 content of my diet, and you'll still see that my linoleic acid levels are, moderately, they're average, but they're not low. So I think that that just reflects a long time in getting those stores depleted. It's also not exactly clear to me how much you have to reduce your intake to get a decrease in this. There are some, subreddits where people share these all the time, and there's a lot of noise in that measurement. So all that to say, my takeaway from this lab panel for me is I am going to be more diligent about my omega-3 supplementation and prioritize some more fatty fish in my day-to-day nutrition. Okay, let's look at my metabolic markers. My hemoglobin A1C, not a great metric, but always worth checking. 4.8, that's reasonable. My estimated mean glucose is 91, and my fasting insulin is a 4.6. Selfishly, would I love for that to be 2 or 3? Yeah, but under 5, I'm pretty happy. Okay, so a fasting insulin under 5 is what I tell my patients I consider optimal. I know there are folks who go even lower for this. It's not clear to me that there's a big distinction between a fasting insulin of 3 and a fasting insulin of 4. Overall, I am in a decent place, and I'm pretty happy with that. My thyroid panel. So this is what you will see in somebody on thyroid replacement hormone. And sure enough, my TSH, which is the pituitary thyroid stimulating hormone that tells your thyroid gland to make endogenous thyroid, is suppressed. My free T4 is normal, and my free T3, which is the active form of my thyroid hormone, is higher. I take my thyroid hormone in the morning. If I didn't take it in the morning, I took my labs, this would look much more normal. But, I wanted to know if my thyroid hormone and how much was getting into the system and what that was going to do. I'm actually going to play with dropping my thyroid replacement down a little bit to see what happens, because I'm not sure that I need quite that much free T3. So I'm going to play with that, and I will be rechecking in a few months and let you know how that goes. Hypothyroidism runs in my family. It's kind of a thing. I don't have Hashimoto's or antibodies. Again, I didn't check those this time, but I have checked them in the past, and they have been negative. So this is just a little gift from my family tree. Okay, cardiac profile. My high sensitivity C-reactive protein is 0.6. I am ecstatic about this because I have been over 1 for a long time, and I was over 3 for like a couple of years, and I have been really just, this has been a thorn in my side for a really long time. And I think it has been the combination of visceral fat loss and better dental hygiene that has really done this for me. I was actually shocked. I had been telling patients up until the week I got these labs back that my hs-CRP was like 1.3, because the last time I checked it, that's what it was. And so I was living in that sort of intermediate range between 1 and 3. Over 3 is bad and suggestive of severe inflammation, not great. And 1 to 3 is average. Below 1 is low inflammation and low cardiac risk associated with that. And so I was living in the 1 to 3 range for a little while, and I was not really happy with it, but it was okay. Anyway, I'm really happy that this is under 1 now, and I'm pretty proud of myself. So, as I mentioned in the introduction, we are not going to spend a lot of time today on my lipid profile because I think this deserves an entire video. But I couldn't just hold it away and like not show you what it is, because I think you'll want to come back and hear the whole video once I show you what's happening here. So my total cholesterol is elevated at 209 milligrams per deciliter. My triglycerides are 45. My HDL is 79. So my triglyceride to HDL ratio is less than 1, which is optimal. My calculated LDL is 121 milligrams per deciliter, which you see flags as high. But my ApoB is 86, which is normal. So how does that work? What does that mean? This is the subject of another video coming shortly to you, where we will dive deep into all of this. I'm going to run you just through the advanced lipid testing here so you know what we're going to talk about. Here's my particle number, total and small LDL particles, the size, HDL particles, VLDL. My LP insulin resistance score, LPIR, is less than 25, which you probably could have guessed based on my triglycerides and HDL and probably my fasting insulin, but nice to see it here. We are also going to talk a little bit about ceramides, which is a very new thing and one that is even new to me, but I'm excited to be incorporating more into my practice and teach you guys about next time we go through labs as well. So let me know what questions you have about lab testing, which ones I left out and forgot that we didn't talk about that you want to hear about. Put them in the comments below. Until next time, take really good care.